Okay, so Peter, 32 years old, male patient, complain of fever for 3 weeks. Proceed, doctor.
Hello. Hello,
Hello?
Dr. Zareen, one of the medical doctors in this hospital today. So, am I talking to Mr. Peter, 32 years old?
Yes, I am.
Okay, so we are here to talk to you about your medical condition today. So, can you please tell me what brought you to the hospital today?
For the last 3 weeks, I feel that I have high body temperature.
Okay, I'm very sorry for your suffering. So, have you measured the temperature?
Yes, I checked it. It was about 38.1.
Okay, so is this the first time this kind of fever is happening to you?
Yes, it's first time for me.
Okay, and does this fever come and go, or is it present, persistent all the time?
It's present all the time, but if I took paracetamol, it a little bit decrease.
Okay, and along with this fever, raised body temperature, do you have any excessive sweating?
No,
Have you noticed that your clothes get drenched with sweating?
no drenched sweat.
Okay. Any shivering or feeling chills?
No body shaking also.
Okay. Have you noticed that this raised body temperature is more in the evening?
No specific time.
Okay. And no specific time? Okay. And along with this fever, do you have any headache?
No headache.
Okay. Any cough?
No.
Any breathlessness?
I don't have breathlessness, but I feel tired.
Okay. How long are you having this tiredness for?
With the same period, with the same duration.
Okay. And do you any tummy pain?
No.
Any tummy discomfort?
Yes, I feel a little bit some tummy discomfort in my left side.
In your left side, in the left lower part or the left upper part?
Left upper part.
Okay. And how long are you having this tummy discomfort for?
This is about 10 days.
10 days?
Yes.
Okay. How would you describe this discomfort? Is it a pain?
Not
Is it
dull
painful?
ache. No, not so
Dull
much.
aching
It's dull
pain?
aching. Yes, dull aching.
How would you grade the severity? Is it on a scale of 0 to 10,
It's 4 to 5.
4 to 5? And have you noticed anything that increases the pain?
No,
Anything that relieves the pain?
no,
Any relation with food, like after food, is it worse? Or if you do not take food, it is worse?
no relation to any meal.
Okay, does it go anywhere, this pain?
No, it's only in the left upper.
Okay. And along with this tummy pain, do you have any throwing up, feeling sick?
No,
Any burning chest pain?
no,
Any acid feeling, taste in your mouth?
no,
Have you noticed that you're getting paler day by day?
no.
Okay. This tiredness you're talking about, this is more on activity?
Yes, with activity.
Okay. And may I ask you, what about your water work? Any changes in amount, color, or frequency?
I noticed only one time it's a little bit dark or red like this. Only once I noticed.
When was this?
Once, one time only.
Um, one time only.
Yes, before 1 week.
It,
It was before 1 week.
okay. Did you have any burning pain in your water work?
No,
Okay. And do you have any pain in your water work now?
no, no.
Okay. So dark urine, you said. Any changes in the amount, like a decrease in amount of your water work?
No change in amount.
Okay. Are you suffering from any known medical condition?
No,
Do you take any medicine on regularly?
no,
Okay. And what about your bowel habit, back passage? Any changes in consistency?
no change.
Okay. Have you noticed any blood coming out from anywhere of your body?
No, never.
Any bleeding under the skin?
No,
Okay. And uh, okay. Do you have any joint pain?
I don't have joint pain, but I have back pain.
Back pain? Which part of the
Yes,
back?
the lower part.
Okay. This back pain is for how long?
It's about 1 week.
1 week. And this pain, is it does it increase on movement?
Yes, it's increased with movement.
Okay. And do you have any skin changes anywhere?
No,
Any no rash, right?
no rash. Yes.
Any weight changes?
I feel that I decreased about 3 kg in the last 3 weeks.
Okay. Was it intentional? Any changes in
No,
your appetite?
no, no appetite. I feel it's not like before.
Okay. And okay, so have you noticed any lumps and bumps anywhere?
No,
Any itching?
no,
Okay. And have you recently traveled anywhere?
no. I didn't travel.
Have you come in contact with any sick patient?
No.
Okay. At this point, I'd like to examine you, if that's okay.
Okay.
May I know your vitals?
Vitals, blood pressure 130/76, temperature 38.2, pulse 110, respiratory rate 16.
Okay. And is there any postural drop?
No,
And okay. And I'd like to check the neck glands. Any lymphadenopathy?
no lymph node, no lymphadenopathy.
Any anemia or jaundice?
No.
Okay. And I'd like to check the abdomen for any organomegaly.
You did not find organomegaly, but you found just palpable spleen.
Okay. And just no ascites
No ascites,
and no hepatomegaly, no ascites. And any scar?
no
Um,
scars.
any edema, leg edema?
No.
I'd like to auscultate the precordium for any murmur.
Okay, you found pansystolic murmur on the left sternal edge, increase with inspiration.
Okay. And Mr. Peter, do you have any racing and pacing of your heart?
Yes,
Since how long?
it's about 3 weeks also.
Okay. And for 3 weeks? Okay.
Yes.
And okay. Do you have any shortness of breath?
Yes, I have short breath.
Oh, yes, you told me about it. I'm sorry.
Yes,
And I okay. So what do you do for a living?
I am teacher.
Teacher. Okay. I'd like to ask you some sensitive questions. I'm sorry. But
Okay.
so do you smoke?
I am smoking 10 cigarettes for the last 5 years.
Okay, Mr. Peters, smoking is very injurious for your health. I'd like to advise you to stop smoking. We have very good smoking cessation clinic where I can refer you. And I'm sorry to ask you, do you take any recreational medicine?
Like what, doctor?
Like any recreational medicine through your blood channel, like cocaine, heroin?
Yes, I took through blood channel.
Okay, and how long did you take it ago? When was it?
About 2 months, 1 month. Always I am taking the weekend with my
Okay,
friend.
okay. And have you ever shared the needle with your friends?
Yes, yes.
Okay. And do you drink alcohol?
Regarding alcohol, yes, I drink about 10 unit beer the week.
Okay. And have you ever had any blood transfusion?
No,
And I'm sorry to ask you this. Do you have any long-term partner?
no,
Okay. Any casual contact? I'm sorry to ask you this.
no. I don't have any casual relationship.
Okay. And no casual relationship. Okay. And um, uh, any previous hospitalization?
No,
Any recent surgeries?
no,
Anyone in your family suffering from the same condition?
no.
Okay. And any itching anywhere?
You asked me, doctor, no itching.
Okay. And have you noticed any yellow coloration of your eyes?
No.
Okay. I want to check if the patient has any splinter hemorrhage.
Okay, you want to examine? You still have now 3 minutes. Okay, 2 minutes. Okay,
Okay.
so
Two
this is
minutes.
yes, 2 minutes. I will share this quickly. Share screen right now.
And
You see anything now
I'm
in the
sorry,
screen?
no picture.
Yeah.
No picture yet.
Now, now, any picture?
Sorry, sir, no picture.
Okay,
Okay,
now,
now it's
okay,
coming.
okay,
Yes.
now, okay,
Uh, yes, now it's there. And is there
okay.
any Osler's node or Janeway lesion?
Okay, you found this is in the nail. You will searching for Osler nodes. Okay, this is Osler node and Genway lesion. Okay.
Okay, and okay, so yeah, Mr. Peter, so what are your concerns?
What do I have, doctor?
Okay, so Mr. Peter, so from what you have told me and what I have examined, you most probably have a condition, we call this in our medical term, infective endocarditis. Don't bother about the term. This happens when there is a bug infection inside your heart, specifically the lining, the covering of your heart. And that is why you're having all these symptoms, like you're having fever and you're having racing and pacing of your heart. So it could be related to the recreational medicine that you have been taking. It could be one of the causes. And there could be other possibilities as well. So I'd like to run some tests on you and I'd like to admit you. And we will do a jelly scan of your heart and tracing of your
Mm.
heart. So do you have any more concerns?
No, thank you, doctor. Time, doctora. Okay. Well done, doctor. Well done. So
Thank you.
we will comment at the end of the case. So give me, please present your finding.
Okay, Mr. Peter, 32 years old gentleman came with fever for 3 weeks, and he gave history of uh, a tiredness and a history of dark urine, most and tummy pain and decreased weight and racing and pacing of his heart. He gave history of IV drug use. On examination, there was a systolic murmur in the left parasternal area and just palpable spleen, um, and raised body temperature.
Okay.
There
So
is a splinter hemorrhage and Osler's notes.
there is stigmata of infective endocarditis, right? Okay. So what
Yes,
the investigation you will do for this patient?
I'd like to do endoscopy, ECG. No, sorry, not endoscopy. Echocardiogram, color Doppler.
Before echo, you want to do anything?
I want to do blood culture. I want to take 3 samples of blood culture, ECG, and CBC, CRP, and I want to do fundoscopy of his eyes
You
and
have to offer
urine
in the
lips.
examination. Okay. You have to offer in the examination.
Oh yes, and
What you will see in the fundoscopy. Suppose if he let you to take the chance, what you will see or searching for.
I am searching for Roth's spot.
Okay. So Ross spot is immunologic phenomena or vascular phenomena?
Vascular phenomena are the splinter hemorrhage, splenomegaly, and Osler's
GNV
nodes,
lesion. No, Osler
Janeway
node
lesion.
is immunologic. Osler is immune, Ross spot immune also. Okay. So you will do a routine investigation, as you said, CBC, SR, CRP, liver function, liver function. You will do blood culture, 3 sample 1 hour apart, okay, from different site. You will do echo. What do you expect to find in the echo to confirm your diagnosis?
I would find vegetation in the valves.
Or you may find what else?
And murmur. I would find the
No,
valve and
murmur you detect by your stethoscope. By the echo, you may find vegetation. You may find abscess. You may find valve dehiscence.
oh,
So,
oh.
do you have any criteria for diagnosis infective endocarditis?
Yes, there is the criteria where there has to be a
What
pathological
is the
criteria and
what is the name
uh,
of the criteria, and give me what is the definite diagnosis?
uh, it's the Jones criteria and
No, Jones
the death.
Jones criteria for rheumatic fever.
Oh, I forgot.
Don't mix between rheumatic fever and infective endocarditis. Infective endocarditis is very, very common in the exam. Okay.
Yes, sir.
So what is the name?
I'm sorry,
Duke.
sir. I forgot.
Okay.
You
Modified.
modified Duke's criteria. Yes.
Yes. Okay. So you need what is the component of modified Duke criteria?
There is pathological evidence and echocardiograph evidence, and blood culture should be positive.
Forget about
There,
pathological, because pathological, this is for autopsy. You are taking the heart to forget about this. What is the major criteria and the minor criteria?
the major criteria should be the positive blood culture and the echo finding and positive blood culture
For
and
com-
immunologic phenomena embolic.
no.
Uh,
Positive blood culture, complete the sentence to be very accurate. Positive blood culture for typical organism, okay? Because
Typical
if positive
organism.
blood culture for atypical organism, this will be minor criteria, okay? So
Yes,
positive blood culture for typical organism, echo finding for infective endocarditis,
echo
as you
finding.
said, either vegetation, abscess, or valve dehiscence. And the minor criteria?
Minor criteria is there is a raised body temperature, these immunological phenomena, and
Yes.
there's embolic phenomena.
Okay. And I
IV
said
drug use.
no. Okay, predisposing a heart disease like IV drug use, patient on hemodialysis, patient permacath, any way to allow for bacteria to enter the bloodstream. This is considered one of the minor criteria. And I said one, which is blood culture for atypical organism. Okay.
Oh yes, that one too. Yes.
Okay. So what are the treatment for this patient?
Treatment should be IV antibiotic, depending on the native valve or organism.
Okay, but did you ask about the allergy of the antibiotic?
No, I did not.
This
Okay.
is very important. In any case of fever, you suspect, you will request for antibiotic. You have to ask for drug allergy. This is very important. This is also the tricky in the exam. Okay. Okay.
Yes.
So, okay. Tell me what are the indication of surgery for infective endocarditis?
Indication one of the is aortic root abscess
Yes.
and refractory antibiotic is resistant, antibiotic not working,
Good.
and heart failure most probably.
Yes. And the multi-drug resistant organism, fungal, and very large vegetation also. Patient recurrent systemic immobilization. All of these are considered indication for in surgery for infective endocarditis. Do you know what is the culture negative endocarditis causes?
It's Coxiella and Brucella. No,
Brucella and what? Coxiella and what else? One is very important.
I can.
Partially treated patient with antibiotic. Okay, this will make the culture will be negative. Okay. Okay, doctor.
You okay? You mean like patient already on treatment, partially treated?
Patient has fever like this one. He went to one doctor and they gave him antibiotic. This will make the culture will be negative. Okay, if he did the culture during antibiotic use. Other causes
Okay.
of culture negative endocarditis, as you said, Brucella, Coxiella, Bartonella, and Hasek group. These are all culture negative endocarditis. Culture negative because the culture will be negative, or at least it will take a long time to be positive. Yeah, that's why in the lab, if you suspect any patient to be one of these, you have to label to the lab that I suspect, for example, this has to take a long time for culture, may up to 6 weeks or more. Okay. So I want to comment for you started very good in the history for the analysis of the high temperature. Okay. First, you asked about first time, onset, course duration, and the association. Okay, and what increase and what decrease, and you try to find a focus of infection started by the head. But I don't know why you shift. You go. It's the best way to go as if you are CT, taking the patient anatomically from up down. You go, for example, just imagine the patient in front view. You go to the head, any headache, neck stiffness, sore throat, ear discharge, neck pain, then go to chest and cardiovascular. If you go here, you can catch it early, okay? Any chest pain, any awareness of your heartbeat, any cough, any shortness, and so on. Then go to the abdomen, ask about the GIT, and ask about the urinary cyst. And don't forget the general. Took a long time to ask about general, doctora. Although this is fever, okay?
Okay.
With me? Okay. Also, very important point. I will tell you something. The examiner focus on some things in the you have to mention, like allergies. This is very important. For example, if you are screening for source of infection and you did not say ear discharge, no, not a big problem. But if you did not say ask about allergy or travel or exposure, as you did exactly, or sexual history or IV drug user, this is very fatal. Okay. Don't forget to ask about weakness and vision problem in the infective endocarditis because of the embolic manifestation. May affect the eye, may affect neuro, causing a stroke or something like that. Okay. This is
Okay.
regarding history. Quickly recap regarding investigation. We'll start by routine investigation. CBC, ESR, CRB, liver function, renal function. You will do ECG. What is the value of ECG in patient with infective endocarditis? This is a question for you.
ECG? Oh,
Yes.
I want to check for heart block.
Yes. This indicate?
Aortic root abscess.
Yes, excellent. Aortic root abscess. Okay. And you will do also blood culture. As we said, 3 culture 1 hour apart from different site. Okay. You will do echo. Right. Then treatment it accordingly. So if I ask you about this patient, he's IV drug user now. What are the valve lesion? I told you there is bensostolic murmur on the left sternal edge, which increases with inspiration. What is the murmur? And what do you want to treat? And what is the most common organism? 3 questions.
In the left parasternal edge, it is most likely to be tricuspid regurgitation, TI.
Yes, excellent. What is the common organism in this patient?
Staphylococcus aureus.
Excellent, Doctora. So what is the medication you will give mostly?
Flucloxacillin and vancomycin.
Yes, it depends on the sensitivity. If MSSA, it will be flucloxacillin. If it's MRSA, you'll go to for vancomycin. Okay, so continue. Then we have modified Duke criteria for diagnosis. To diagnose definite infective endocarditis, 2 major or 1 major plus 3 minor or 5 minor. This is definite. Possible if 1 major plus 1 minor or 3 minor. Major criteria, as you said, blood culture for typical organisms, which are like Staph aureus, Strep bovis, Strep viridans. These are very common. What is the value of you if you found Strep bovis in patient blood culture infected endocarditis? You did culture and found Strep bovis. Do you want to do
Indicates some
anything?
kind of colon cancer.
Yes, you have to do colonoscopy. Excellent. Another
Excellent.
bacteria, do you know, also associated with colon cancer?
Enterococcus faecalis.
No, this is wrong. It's Clostridium septicum. This is common with colonoscopy. Only 2, Clostridium septicum and Strep bovis is the most common. Okay.
Okay.
So blood culture for typical organism, as we said, and echo finding of infective endocarditis like vegetation, abscess, or dehiscence. And minor criteria: fever more than 38, vascular phenomena like splinter hemorrhage or Genway lesion, immunologic phenomena like Russell spot or Osler's nodule, a predisposition for heart disease, Bermicas, hemodialysis, patient IV drug user, and blood culture for atypical organism. Okay, so as you said, indication for he may ask you treatment according to antibiogram and the sensitivity and the most bacterial resistance in every area and according to culture and sensitivity. Okay. Then indication of surgery, you said either severe heart failure, severe valve dysfunction, large vegetation, aortic root abscess, multi-drug resistant organism, fungal infective endocarditis, all are indication for surgery. I want to ask 1 or 2 questions. What is the indication for prophylaxis for infective endocarditis? Or by another way, for whom you are giving prophylaxis against infective endocarditis?
In a case where there is a open gastrointestinal surgery.
No. My question for whom, not for what. 2 part. I choose 1. For whom, not for what procedure. For whom? You got my question? Who's the people
Yes.
are candidate for prophylaxis?
I'm not sure.
Okay, 2B, one previous infective endocarditis, the other B is prosthetic valve disease. And if the patient has congenital cyanotic heart disease, which is not repaired or partially repaired, or patient has cardiac transplant in the first 6 months with abnormal valve. Okay?
Okay, sir.
Okay, I remember another question also. You told me you'll do echo. What type of echo you will do? Transesophageal or transthoracic?
Transesophageal.
No, you will do transthoracic because it's easy access and very, and it can be done even portable. But transesophageal need preparation. There is some indication for transesophageal. I don't think he will go deep, but just for info, when you will go for transesophageal echo, if you have patient with high suspicion of infective endocarditis and the TTE is not diagnostic or complicated prosthetic valve endocarditis, and you want to rapid diagnosis. Okay, doctor. You want more questions? I asked any question can come in infective endocarditis. Do you want one more or one more?
Sir,
Okay, last one. Okay, last one. Now, do you have any other non-infective endocarditis causes? Now we have infective endocarditis and
oh,
non-infective endocarditis.
there's this one with Liebman sac SLE.
Yes, and
I don't know the other one.
yes, Liebman-Sack endocarditis with SLE, Maranatic endocarditis with malignancy. Okay, you will
Okay.
find, yes, excellent doctor, as Adis Mogas. Maranatic endocarditis, you will find no fever, no leukocytosis, no murmur, just only small vegetation. Excellent, doctora, well done. Just only to ask about weakness, vision problem, okay, and
Yes, sir.
ask about allergy in the
Drug
history.
allergy.
Yes, I want to just focus on the history, LCC, the doctor, he is examining and checking your approach, even if he did not find or get the diagnosis, just your approach. You have to ask, there is some criteria in his paper, you have to ask some criteria, not all questions. So don't bother yourself to ask all system or all questions like this. There is some are considered for him crucial. You have to ask. If you did not ask, he may affect. Also, important point, not to forget managing patient concern because it was a very little time for it. Because managing patient concern, as I said before, it's equal 4 mark, exactly as the examination, exactly as history taking. You are taking, for example, 9 minutes asking the patient. This is for 4 minutes only. And the other side, 2 minutes, what is your concern? And it is will be answered easily. You will take for mark. You got my point? This like this. So don't take a long time and forget the managing patient concern because this is a skill and a very dangerous skill because it is out of 16, I think the pass mark is 11. If you affected in one borderline and one unsatisfactory, bye-bye. If two borderline, you will just pass. Yeah. It will be at risk. Okay, doctora?
Yes, sir. Sir,
Okay.
could you please repeat the what you said about antibiotic prophylaxis?
Yes, antibiotic prophylaxis, try to keep it in your mind. 2B, prosthetic valve disease or previous infective endocarditis. And the other patient with congenital cyanotic heart disease, which is unrepaired or partially repaired, or I mean still there is a residual defect, or the patient with cardiac transplant in the first 6 months with abnormal valve. These are the indication.
Okay. Thank you, sir.
Okay, if anyone want to ask or
Sorry.
repeat anything, alaikum salam.
I just have a question regarding the skill for differential diagnosis in such case. What should be on our differential list other than the diagnosis of infective endocarditis?
Yes, there sometimes he did not ask about differential diagnosis. Sometimes, okay, but it will take the all the case together. Yeah. But if you want to put differential for this patient, you can put anything with fever. For example, patient has back pain, you can put brucella. Okay, brucellosis can sometimes affect the spleen also. Okay, you can put typhoid. So many differential.
Okay, thank you.
Okay, doctor. Anyone any question, or you want me to repeat any point?
معلش يا دكتور طلعت، هو بالنسبه للماركس هو يعني هم 16 درجه، 4 منهم الكونسيرن بيبقى يعني تقسيمتها ازاي؟ طبعا يا ريت حضرتك تقول لي.
Okay, doctor, skill patient concern, it will be in talkative station, in communication, and in LCC. Every skill 4, okay?
تمام.
In communication, you have 2 cases, and in consultation, 2 cases. So we'll go to managing patient concern. What you want from managing patient concern? You have to answer the patient concern. Don't overlook the patient concern. Don't ignore the patient concern. You have to be in a very react well with the patient concern. This is very important. It's very easy because he will ask you like this: what do I have, doctor? You have a disease called infective endocarditis. Don't be bothered about the name. It's a bug infection of the lining of the endocard. And you will do blah, 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 okay? And in communication, he will ask you about some concern, like, I want to go home, I want to visit my, like this. You have to answer. This is equal 4 mark, and this is easy to collect.
Okay. Thank you. Thank you.
Any other question before going to the short case? Anyone want me to repeat any point in the topic? Okay. I think Dr. Ismail, I think will for short, or who? Dr. Athar.
Hello, Assalamu alaikum, sir.
Alaikum salam, Dr. K. How are you?
Alhamdulillah.
Okay, you can take the short. I think the other doctor he did not attend.
Okay, I will try. First time I have to take.
Okay, it's short. It's short. Just short. Clinical. It's 6 minutes only. Okay.
Yes, yes.
So he's male. For example, he's Omar, 35 years old, complaining of lethargy. Examine his abdomen.
Complaining of lethargy, eh?
Yes.
Okay, can we continue?
You'll start. I will do 6 minutes. Okay.
Okay.
Okay. Let's go now. Okay. Yalla.
Okay, first, I will introduce myself to the patient. That my name is Dr. Azhar, and today I'm here to check your tummy. And first, when I will enter the room, I will check the scenario, instructions, and then I will wash my hand, and then I will just inform the patient that today I'm your doctor and I want to your tummy. Then I will stand at the foot end of the patient, and I want have a general look. And before the general look, I want to request the patient that can you remove your clothes? Because
Yes. Okay.
I want to see inspection. Is there any scar, any deformity, any visible pulsation, or the patient is in discomfort? Any tummy swelling?
No.
Okay.
Normal. No, nothing.
Nothing normal. Then on, I will start my examination from the hands. I will see any clubbing, any colonakia, any palmar edema, any Dupuytren's contracture, any bruises.
No. Normal.
Normal. Then I will check his pulse.
Pulse normal. Pulse normal.
pulse normal. Then I will see his blood pressure lying and standing. Blood pressure I
Normal.
want normal. Then I will check any lymph nodes.
Normal
check the-
also.
Nothing. Then I will check the eyes, any pallor or jaundice.
Patient looks pale.
Patient look pale. Okay. And jaundice.
You did not appreciate any jaundice, but he's pale.
Pallor. Then I will check his mouth for any ulcers, any enlargement of the tongue, anything you want to check.
No mouth ulcer. No.
No mouth ulcer. And then I will check. I will go to the abdomen. I will do the inspection. Any scar, any
No scar.
no scar. And then I will check any tummy swelling, any ascites like this.
No ascites.
And I also want to see any signs of chronic liver disease on the chest, any spider nevi, any gynecomastia, capillomatosa.
There is no stigmata of chronic liver disease in his chest.
Okay, then I will do the superficial palpation. And before this, I will take permission from the patient. I will be very gentle, and if you will feel any pain, please let me know. And
Okay.
I will do the superficial palpation. And
Okay, you found hepatomegaly 3 centimeter below the last costal margin in the liver, and there is also splenomegaly 4 centimeter below the costal margin, left costal margin.
Okay. And then I will also check the kidney for
No
movement.
palatable kidney. Yes, no.
And then I will also offer for digital rectal examination.
No need.
No need. Then I will check the lower limb for any swelling, any pitting edema.
No swelling edema, but there is a leg ulcer in his leg.
There's a leg ulcers.
Mm.
Leg ulcers. Can I see a leg ulcer?
No picture, but there is ulcer in his left leg.
Okay, leg ulcer. It is oozing. What is the color? It is oozing, painful. This leg ulcer.
Yes, it's painful, but it's not oozing.
Painful, eh?
Mm.
But not oozing. It is no lymphadenopathy, as you told.
No lymphadenopathy. Do you want to do any examination in his face? Now we have hepatosplenomegaly for this patient and pallor.
Face.
Yes, apart from pallor and jaundice and these things.
I want to see any parotid enlargement, any then wasting of the temporalis muscles. And then I want to see about the patient's weight. Weight is cachectic or
Patient weight is low weight, underweight.
Patient is underweight.
Yes.
On the face, as you asked me, I could not remember that.
So 1 minute remaining, doctor. So
then I will request the patient he can wear the clothes, and thank you very much.
Okay.
And I also want to do any forget anyone shifting dullness, ascites.
No ascites, no negative. No.
No shifting dullness.
No shifting dullness. Yes. So what is the present your finding?
Okay. After examining and this gentleman is having only the positive thing. This patient is having pallor and hepatosplenomegaly, and on the face, since I don't have picture, maybe there may be deformed bones. So deformity of the bones maybe.
Yes,
so,
okay. I will. If you ask me about the face, I will tell you there is enlarged cheek and there is frontal bossing.
Frontal bossing. So on the
Yes.
basis of So on the basis of this, my topmost diagnosis is thalassemia. And
Okay.
and then the differential, I will also go, a patient is having paler hepatosplenomegaly, chronic myeloid leukemia, myeloproliferative disorders. Then
Excellent.
below I can put the lymphoproliferative disorder, but it is there is no lymphadenopathy, so it is a case of the lymphoproliferative. Then
Excellent.
at the end I can put hemolytic anemia. But in case of hemolytic anemia, I want to see the jaundice. There is no jaundice, so I also rule out this hemolytic jaundice also.
Okay. So if I ask you, patient with thalassemia, how many scars you may find? Not in this patient, in general,
How
when
many
you are
scars
examining. Yes, not supposed to be in the same time, but how many scars you may find for any patient with thalassemia?
on the abdomen? There may be
Yes,
scar of
all in the abdomen.
cholecystectomy, and there is a one scar on left side of splenectomy. Two scars.
Okay, if you found a small scar, hypopigmented scar near the umbilicus, what will most be?
There may be peritoneal.
No, this is a
Maybe
scar for
maybe laparoscopic scar. Very
No,
small
this
scar.
is subcutaneous injection for iron chelating agent. It will be like this, hypopigmented scar, mostly in abdomen beside his umbilicus. So what is the investigation you will do for this patient thalassemia?
Thalassemia, most important, I will do the basic investigation, CBC, LFT, RFT, electrolyte, ESRC, reactive proteins, and then to confirm my findings, I will do the ultrasound, and then I will do the hemolytic screening to see the retic count, and retic count will be raised, haptoglobin will be decreased, and then I will ask LDH and unconjugated bilirubin.
Bilirubin.
And,
Okay.
and to search for the cause of hemolysis, I will go for the hemoglobin electrophoresis. And there may be hemoglobin A2 may be raised in this case if this is a case of thalassemia.
Yes, excellent. And still too important
for the investigation.
Yes, you can do also iron study because the patient is taking iron to check for iron.
Yes, iron patient.
Yes,
iron.
and genetic testing. How do you know other causes of congenital hemolytic
last
anemia?
Last one, what you told?
Genetic testing.
Yes, the genetic testing.
Do you know other causes of congenital hemolytic anemia?
There may be hereditary spherocytosis. There may
Yes.
be G6 phosphate dehydrogenase deficiency, and sickle cell anemia. Maybe
Sickle cell anemia can present with splenomegaly.
no, it will be atrophic spleen.
But if it is sickle cell thalassemia, can be sickle cell anemia alone. It will be autosplenectomy due to repeated splenic infarction. But if it is sickle cell thalassemia, it will be also maybe splenomegaly. Okay, Dr. Azhar, what is the complication of thalassemia?
Complications of the thalassemia, there may be complication of the disease itself because the patient may present with anemia, and due to this anemia, patient may have heart failure, and also there will be bone deformity, there may be gallbladder stone and leg ulcers, and there may be complications of the blood transfusion, like the patient is taking multiple blood transfusion, patient may develop hemochromatosis, secondary hemochromatosis, and viral infection. Viral infections of any type he can develop, like cytomegalovirus, it can develop infectious mononucleosis, and there may be complications of the injection, this iron injections and tablets. If the patient is taking iron injections, IV, like deferoxamine, the patient may develop sensory neural deafness, there may be renal impairment, there may be corneal opacity. And the patient is taking oral iron supplements, there may be 2A, granulocytosis or arthropathy patient may develop. And oral injection, oral preparation, they are protective for the heart, while the injections, they are protective for the liver.
Excellent, doctor. Excellent. What are the indication for repeated blood transfusion for patient with thalassemia?
If the patient is having rupture of the spleen and that there is an increased increased requirement of the body for the blood transfusion, or there may be neutropenic sepsis or hypersplenism.
No, this is indication of splenectomy. No, my question, indication for repeated blood transfusion.
Repeated blood transfusion. If the patient is anemic, and his hemoglobin is less than 7.
Yes. Yes. What else? Excellent, doctor. And if there is any complication like a gross failure, gross retardation, any organ failure, these are indication. And what is your target for hemoglobin?
It should be more than 10.
Excellent. So now till the indication. Yes, to avoid extramedullary hematopoiesis. What is the indication of splenectomy? You were mentioning before.
Yes. Yes, I mentioned you the rupture of the spleen and increased requirement of the blood transfusions and neutropenic sepsis, hypersplenism, and very huge spleen, it pressing the other organs like stomach.
Yes, causing pressure symptom and increased requirement of blood transfusion. And the last question, what is the definitive treatment for thalassemia?
Definitive treatment is stem cell transplantation.
And yes, excellent.
We will also go for the splenectomy.
Excellent, doctor. MashaAllah. Excellent.
First time I presented the case, short case, first time.
No, but excellent, wallah, excellent. All the question answered fluently and in correct manner.
Doctor, I have confusion. What about what is hypersplenism? I never have a clear concept. What is meant by hypersplenism?
Hypersplenism, this is another name other than huge spleen. Huge spleen, this is spleen enlarged in size and cause pressure symptoms. Hypersplenism, this means the spleen start to make pancytopenia. It will affect the white blood cells. It will eat all these RBCs and white blood cells and platelet. So it will cause pancytopenia. Now, presence of a spleen became dangerous for the patient. That's why put the patient under the risk of anemia, recurrent infection, bleeding because of low platelet, low white blood cells, and low RBCs. You got it? This is hypersplenism.
You mean to say the spleen size becomes extremely large and is causing pressure symptom, it's causing pancytopenia.
Yes, not only extremely large, just only make pressure symptom or pain, just the function of it is affected and became causing low platelet, low RBCs, low white blood cells, causing pancytopenia. That's why you have to remove it.
Yes.
Okay.
My differential diagnosis was okay.
Yes. You have to put. Now you have hepatosplenomegaly with no stigmata of chronic liver disease. So first differential, and the patient has pallor. First differential, you have to put chronic hemolytic anemia. Second differential, you have to put myeloproliferative disorder. As we said before, myelo, it's bone marrow proliferation. So according to what level the proliferation occur. If it occur at the level of RBCs, it is polycythemia rubra vera. If at the level of white blood cells, it's chronic myeloid leukemia. If at the level of platelet, it is essential thrombocytosis. If at the level of the bone marrow, it is myelofibrosis. These are the four components of myeloproliferative disorder. Other differential is lymphoproliferative disorder, which is CLL, ALL, and lymphoma. And the patient against that, as you said, no lymphadenopathy. Also, you have to put, if you ask it, infiltration, sarcoidosis, amyloidosis, okay? Infection, especially chronic malaria, because it causes hepatosplenomegaly, not acute malaria. Chronic malaria, this will be in patient living in area which is endemic. The spleen increase in size. And the visceral leishmaniasis, we will never see this case Kala-Azar. and other storage disease. This also considered of causes of hepatosplenomegaly. So differential is very, and amyloidosis is infiltration. Yes.
And Gaucher disease also can be put infiltration.
Any oosis, it cause mostly infiltration. So both amyloidosis, sarcoidosis, these things. And if he asked about any investigation accordingly.
Schistosomiasis can be put in the differential.
Schistosomiasis also can cause splenomegaly, and it can cause hepatomegaly because it causes periportal fibrosis, not cirrhosis. It will cause periportal fibrosis and will cause also esophageal varices and give you the same stigmata of chronic liver disease. There will be ascites, esophageal varices, and there will be hepatosplenomegaly, and there will be portal hypertension. It will be the same.
Can cause jaundice. Schistosomiasis can cause jaundice.
Schistosomiasis can cause jaundice by many causes. I think one of them, schistosomiasis, and some worm can go in common bile duct and obstruct, and also by the periportal fibrosis. Any other questions?
No, thank
you. You have schistosomiasis in India, I think. It's common in Egypt.
In Pakistan, it may be or not. I'm from Pakistan.
Mansoni? Okay.
Mansoni.
Anyone
Only
want
Egypt.
to ask? Yes, Egypt, and I think some African, tropical, and I think there is another one in Japan and this area. Which cause Katayama fever was, I cannot remember the name of schistosoma. There is Hematobium mansoni and there is another one.
Japonica.
Yes, Japonica. Yes,
Yeah.
Japonica. Yes. Japonica. This causes Katayama fever. Katayama fever, there will be rash and there will be also splenomegaly. Okay. Any other questions?
I have just a minor comment. Just regarding the because I've always made a mistake in the past, and I just want to share just a tip with the rest of the group. For palpation of the liver, just remember to palpate for the right lobe and the left lobe separately, especially if you have got like an obese patient and your hands were small, you might actually miss a left lobe or mistake it for a spleen. The second point regarding the lymph node examination, I think it's might be prudent just to leave it to the last in case you just got to squeeze in time and so on. Although it's important to do, but I'm not sure if it would be the right thing to start it before starting examining the abdomen. And for the
This depends. Okay.
just the last one regarding the differential diagnosis, this is in general for all the stations. Just remember to just have a last look at the age of the patient before answering the question, because in all the stations, sometimes the age might give you a clue as to how to list the differentials when you're asked for. And that's all.
Okay. Thank you, Dr. Amaro. Yes, listing the differential is very important according to the age of the patient. This is very important. Regarding the lymph node examination, I think this is everyone has his own approach for examination, but the most important, he don't forget to do it if you want to do as Dr. Azhar did it or at the end, but the most important not to forget. And regarding the right lobe and left lobe, this is very important also. You have to palpate right lobe. Sometimes left lobe only may be enlarged and you may misdiagnose with spleen. Okay, so this is very important. Thank you, Dr. Amaro. Any other comment or anyone to ask?
Doctor, did you record this session?
I think, inshallah, I did record and he told me recording it because I wish it will continue.
Okay, if you will send, then we will improve our deficiencies.
I wish, Allah, recorded. I will try now to stop. Okay.
Thank you very much, Dr. Thank you very much.
Okay. Assalamu alaikum.